The broadcast is now starting. All attendees are in listen-only mode.
Hey everybody, we'll get started in just a second. There we go. Hey, good morning, good afternoon, and welcome to today's webinar. This is Dr. Evan Gwilliam. Most of you today, it looks like on this call, are clients of PayDC software. So we're glad to have you here. I hope you find this helpful. For those of you who are not clients of PayDC, thanks for joining us. I'm not actually going to talk much about the software, but we're still glad to have you here. And if you want to know more about the software, please reach out to me and let me know. My email address is on the screen. I think you can see. I am Dr. Gwilliam. I'm the clinical director for PayDC, and I'm going to be talking to you today about diagnosis coding stuff and documentation. And so I want to make sure that you leave this with something useful that's going to help you create better records and feel like you're better equipped to do what you need to do. And I hope you don't mind, I got the webcam on. I find that I like to gesture while I'm talking, so hopefully you'll find it helpful. Let's see, I also want you to know that I will be watching. I'm looking at a different monitor over here, the questions as they come in. So I'll try to keep an eye on those. And if they're relevant to the topic at hand, I'll try to respond to them right then. Otherwise, I'll save it for a little later. Let me open that up so I can see it real easy. So this is a CE-based webinar, which means that I'm going to throw some quiz questions at you at the end. If you wish to get your credit hours for attending today, you'll need to complete the quiz. Hopefully get them all right. I will do my best to make the answers really clear to you, but I'll tell you what, if you don't listen, they might be too hard. But I'll tell you exactly what the answers are. So when we get there, we'll get there and we'll work on it together. Again, we're reviewing diagnosis-related stuff in the documentation. So I think that's it. Feel free to submit questions as we go through, and off we go. So I am Dr. Gwilliam again. I have a couple of degrees in business, and I'm a chiropractor. And I went to Palmer College, and then afterwards I got a bunch of certifications, a whole bunch, and that makes me qualified to teach this stuff. I know what I'm talking about. I travel around the country. I teach seminars on documentation and compliance issues. I do chart audits for people who aren't even PayDC clients. I do work on for doctors who are in trouble with their state board. I'm helping them try to kind of recuperate. I recently went and testified at a hearing to help a doctor who was in trouble with the board. And so I get around, and I'm hoping that the information I've gathered here for you will be helpful and relevant. Just to make sure that we're on the right track here, could I just have, I'm going to regret asking this, someone just say, yes, you can hear me. Just throw it in the question thing, because I just want to make sure I'm not talking to myself. I'm watching. There we go. Okay, that's enough. Nobody else now, because I got the first one in. Sometimes a whole bunch of people do it at once. All right, great. So I know that at least, Mark, at least you and I can hear each other, or at least you can hear me. All right, so here's what we're going to do today. We're going to talk about some guidelines first, and then I'm going to get into this thing I call the diagnostic statement. It's all about capturing the information that your record needs to tell the proper story. The diagnosis is what establishes the need for all the care that follows. And so we're going to look at some fundamentals. I'm actually going to spend about half the time that we're going to be together on rules and guidelines, because it'll kind of form a foundation. And then I'm going to take a clinical example that I pulled together, and we're going to create a diagnostic statement from that example so that you can see as an auditor, an Icd-10 expert, what I would want to see in the records to make sure it all supports and matches. Okay? So first, let's talk about some Icd-10 guidelines. When you look at the rules for Icd-10 as they pertain to chiropractors, you have conventions. So like if you were to open, in fact, I'm going to show you. I was just looking at it as I was prepping for this. This is actually a 2018 edition, but here's my Icd-10 book. Whoa. And I don't know, it's a big one, it's heavy. And I don't know if any of you, still buy your Icd-10 books, but this is where it all comes back to. And there's a ton of codes in here. I just got contacted by the Alaska Chiro Association. And so some of you, we have several clients up in Alaska. For some of you on the call, I didn't get a chance to check. You may have heard that Primera Blue Cross in Alaska has made it clear that they plan to audit records based upon the excludes one rule found in ICD-10. And so if you don't understand how the excludes one rule applies, you may get claim denials. And so I'm going to do my best to go over that a little bit later. But you need to understand that at the end of the day, it's what's in here that matters. And man, I wish there was a shortcut or a cheat sheet for excludes one, edits or something, but nothing comes to mind. I'm sure there might be a way if we think about it for a while, but I want you to understand the background, and then we can find shortcuts after you know the basis, okay? So we're going to talk today about some of the conventions found in section 1A of this book. Maybe next month when I'm going to talk more about diagnosis coding in a different way, I'm going to go over some other guidelines, some more general guidelines as well before I get into the other topic. But you should understand that number 4 in this list, a tabular list, that's where the codes themselves are. And sometimes when you look up a code specifically in the book, there's a rule around that code. Those are the rules that dominate. If they violate the general conventions or general guidelines, they dominate. And so sometimes it's important to have access to those references, okay? So let's look at some of the general guidelines. Pat says I'm breaking up. Pat, I don't want to break up. I want us to stay together. So don't leave me. I apologize. I pay for a really good internet connection, so I'm hoping it's on your end and not on mine. So I'm going to dive right in and just talk about a few general conventions. Hi, Rayanne. How you doing? So placeholder X character. In the guidelines, we look up, what is that thing? What does it mean, right? And some of you have seen some codes and you know what I'm talking about. The placeholder X is in the 4th, 5th, or 6th positions in some codes to allow for future expansion is what they say. And generally it's for codes that have a 7th character. So let's look at these 7th characters and try to figure them out. I was not a fan of the X files, so I'm not real familiar with it, but I just thought that it kind of tied in here. So here we go. Now, this is a shot right out of a coding book, right? This is actually the coding book that I helped create when I worked for ChiroCode years ago. Some of you may have met me back in those days, back in 2014 and 15, just so you understand my background with ICD-10. I became a certified ICD-10 instructor through the American Academy of Professional Coders, one of the only chiropractors to do so, to my knowledge. And I helped ChiroCode build this chiropractic-specific ICD-10 resource, and then we put together a seminar, and I went all over the country and trained doctors on how to get ready for it. And I had a 6-hour seminar where I talked about ICD-10 for 6 hours, and everybody in there was freaking out, and I was teaching all these details and this hard stuff. And then ICD-10 kicked in 2015, and everything was fine, and it wasn't a big deal. And looking back, I probably could have done a 2-hour seminar, and it would have been good enough. But I was thorough, and I made sure it was 6. So I remember what we had to do, and I'm going to make sure I hit the highlights for you today, all right? But we're not going to spend 6 hours, okay? So what you're looking at here is the codes under S16, right? Which is a group of codes for injuries to muscle, fascia, and tendon at the neck level. And I want to point out the instructions for the 7th character. These codes describe conditions that patients can have, and that 7th character provides extra detail. And in this case, it's either an A, a D, or an S. Now, just so you know, there are more than just those 3 options for 7th characters, but chiropractors don't use the codes that require other options. If you did a fracture code or a burn code, those have more 7th characters. And we don't typically use those codes or treat those types of conditions. So because of that, we typically just need to know about the A, the D, and the S, which are the most common, okay? So we take a look at S16.1XX, and then there's a blank there to fill in with the A, the D, or the S. That code is strain of muscle, fascia, and tendon at the neck level, okay? The question is it the initial encounter, a subsequent encounter, or a sequela? And what do those really mean? Before we get into that, let's look at the next one. Here is S39.01, which is strain of muscle, fascia, and tendon of the lower back and pelvis. So you can see that this code requires an A or D or an S. So these are codes you may use in your office. So if we go to the guidelines in ICD-10, we look up what does the A, the D, the S stand for? What does it mean? We find these descriptions, these explanations. A is the initial encounter. And at first glance, you think, well, that means it's the first visit, right? And the instructions say, well, the patient is receiving active treatment, including continuing treatment by the same or different physician. So it's interesting that they say it includes continuing treatment. It's not just the first visit. It's the active treatment and the continuing treatment that they receive that's considered active. The D for subsequent encounter isn't just every visit after the first. It's routine care during the healing and recovery phase, such as aftercare or follow-up. So if you were seeing a patient and you're treating them for a sprain or strain, and you say that they are in the healing or recovery phase, then you should use the D as the 7th character. If, however, you feel like they're still in active treatment and it's continuing treatment, then you should use the A, okay? And I'm gonna get into this more. The S is for sequela, and this is for complications or conditions that arise as a direct result of a condition. So for those of you who are really concerned about your credit hours for this, getting credit for this course, one of my quiz questions you're gonna have to answer is, the 7th character S for sequela should be used when what? All right, you have to pick the right answer. When to use the 7th character S? And the answer is when it's a condition that arrives as a direct result of something else, okay? It's not active treatment. It's not the initial encounter or the subsequent encounter. It's something that complicated that came up from something else. That's the answer to the question. Don't forget, okay? A little bit more about sequela. In the guidelines, it tells us that sequela means late effects. It's a residual effect after the acute phase of an illness or injury is terminated. So the example that we're given in the guidance is paralysis after a stroke, right? So you're not treating a stroke anymore, you're treating a paralysis. And so it's a sequela of the stroke. Paralysis is a sequela. And we're told to code first the condition you're treating, and then second, the illness or injury that led to it, which would be the code that has the S on it to show that it caused the thing you're treating. Never code the acute phase of the illness or injury with a sequela, right? So let's see if we understand this. Which character would we use? And you can yell out loud if you want the answers. I can't hear you, you can just hear me. So which character do we put on it if the patient's receiving active treatment? Well, that's easy, that's the A, the initial encounter. Active treatment was part of the definition, right? If the patient's in the middle of a treatment plan, is it the A or the D or the S? Well, the answer is A because it's still continuing treatment for the active care of the case. If they're stable, what if they're now stable, but you're still treating them for some reason? Like you found them stabilized, but you want to do a little bit more? Well, that's the D. That's what that's for. It's the healing and recovery phase of care. What if it's supportive care? You know, it's the aftercare follow-up. That's what D is for, okay? Healing and recovery phase is right in the description for the subsequent encounter, or D as the 7th character. What if they're being treated for the complication of something that's a direct result of something else that's no longer present? They had a problem, it's gone, but it caused a new thing. How do we code for that? We use the S. That's what the sequela means, okay? And that is a quiz question. So just remember that's how to use those. I think as chiros, 99% of the time, we just use the A on all of our codes, and A is the 7th character for what we do because we're treating patients in active treatment. And when they're not in active treatment, in the recovery phase, we release them. Unless you feel like you are treating them, then you use the D. That's how it should be used, okay? In my opinion, as an ICD-10 so-called expert, okay? I'm gonna put quotes. This is the Lego quotes. If I had Lego hands, expert, okay. I don't know if you guys appreciate that or not, sorry. So, okay, so let's talk about some conventions, okay? There's a couple of conventions. If you're looking up ICD-10 codes, in their descriptions, they will say things like NEC and NOS, and it's important we review what those mean. NEC means not elsewhere classified or other specified. It is synonymous with the use of the word other in the code set. So my example here is M53.86 is other specified dorsopathies of the lumbar region. What that means is you did specify what the patient had in the notes, but you couldn't find a code that matched that. An example is facet syndrome. There's no code that adequately describes an acute facet syndrome. Therefore, I like this code, M5386, to describe that. Other specified dorsopathy. You're telling someone that the patient has a back problem or dorsopathy, and you have specified what it is, but it's other because none of the codes in the whole code book in this massive volume includes what you really are describing. And then, of course, lumbar region is described there. So this code is an other or an NEC code, okay? NOS, on the other hand, means not otherwise specified or unspecified. And you may remember from when you've been trained in ICD-10 in the past, or if you ever learned about it way back when, you want to avoid these codes. You don't want to report codes with unspecified or not otherwise specified because it means that your information in your medical record is insufficient to assign a more specific code. An example is M54.9, which is dorsalgia unspecified. That means that my note says the patient's back hurts. And that's all it says, okay? Now, if I said the patient has a strain of the muscles in the back, then I wouldn't need this code because I would have just explained what their condition is and it would include that their back hurts. That's kind of a given, okay? So we want to avoid codes that are NOS or not otherwise specified. So I want to warn you that this is also a quiz question. It is, which of the following conventions is for a code that is unspecified or not coded or documented enough sufficiently, okay? And your answer choices are like NEC or NOS and a couple others I made up. So I'm telling you the answer is NOS, okay? Just telling you. Now, I want to make this as easy for you as possible, as long as you're listening. Here's a few more ICD-10 rules, okay? If you see brackets when you look up a code, in the official code set, if there's brackets, those are synonyms, alternative wording, or explanatory phrases. If you see parentheses, those are supplemental words. They're non-essential. They are not required to be part of the doctor's record, but they're there to kind of help. The word and in ICD-10 means and or, either or. So it doesn't mean and like absolute, like blue and red. It means blue and or red, okay? And then I found this headstone I thought was fascinating. It says that Paul and or Cecilia has been buried there. We don't know which one. Could be both of them, either one. So that's kind of how this applies, all right? So this is an image from an online encoder I use called Find a Code, okay? Some of you may want to look into Find a Code. You can email me if you want to learn more about it. It replaces the books, okay? You don't have to have these massive books. You subscribe, you get in, and then this is, I looked up M48.16 because it's a code that has something in brackets, and I highlighted it here on your screen, Forstier's disease. So if you document Forstier's disease, this is the code for you. You don't have to document it. It's just additional wording in the brackets for explanations. And then at the bottom of your screen, you see I've included one with some stuff in parentheses. So here's a common code that chiros use, right? Sprain of ligaments of the cervical spine. So what I've done here is I've said, look, I've highlighted in here the words in parentheses, ligament, joints. You don't have to specify that it was ligaments or joints is what they're saying. It's in there to kind of help, and it wouldn't hurt for you to put it in there, but they're non-essential modifiers when you see parentheses in a code description, okay? And by the way, all this stuff is going to tie in when we get to the last half of this presentation, which is how to create the diagnostic statement. We're going to borrow these rules to help us figure out how to document properly. Okay, so we saw that the word and means and or. So here's an example. What I've highlighted here is S33, which is a category. The S33 category includes dislocation and sprain of joints and ligaments of lumbar spine and pelvis. And since they use the word and, it means and or. So I want you to read this as in dislocation and or sprain of joints and or ligaments of lumbar spine and or pelvis. In other words, it doesn't have to be all of these things. It can be any of them. They don't have to have a dislocation as well as a sprain. They can have a dislocation or a sprain. It doesn't have to be the spine and the pelvis. It can be the spine or the pelvis, okay? So that's how the word and works in ICD-10. It's just important to remember and understand. Now, if we look up the rules, it talks about what the definition is of the words with and without. With means associated with or due to, which I think is kind of self-explanatory. Just so you understand, if you look up a code and you think it should have an option of something with something and without something else, the default is always without. So to help you remember this, I put an image here of Barbie with and without makeup. Okay, so I found that. I did not, this isn't my Barbie. I didn't remove her makeup or anything. And then another rule in ICD-10 conventions is there are things called inclusion terms. And if you look up a code and there's a list of things underneath that code, these are conditions that are assigned to that code. Let me give you an example. Actually, let me talk about with and without first. No, I have them both here. So if you have a patient with migraine, you have migraine without aura and migraine with aura. And when we talk about the default being without, that means that if I document the patient has a migraine and I don't mention aura at all, then I believe those guidelines basically make it so that it's okay for me to choose the code for without aura without having for me to specifically document that because we're told it's the default. Now, I think your records are better if you go to the trouble to always mention whether or not there's an aura when you have a migraine patient in your records. So I strongly encourage you to document. If the codes have an option of with or without, you should take a moment to add the extra couple words to say it doesn't have this or it does, okay, in my opinion. And the other example you see here of radiculopathy in the bottom right of your screen, this code has a bunch of inclusion terms, all right? And back in the day, maybe in 2013 or 14, I remember a chiropractic neurologist reached out to me and said, hey, there's this great new code set coming out, and I want to be really clear about the difference between neuritis and radiculopathy and radiculitis. Those are three different things. And I'll be honest with you, like that's not my specialty, it's not my expertise, and I can't tell you off the top of my head the difference, okay? That doesn't really matter to me, but it mattered to that guy, and he wanted to know if there were separate codes for that. And the answer is no. If you look up M54.1 under radiculopathy, there's a bunch of inclusion terms, and these other 5 things you see underneath radiculopathy, those are all included. So if I have a patient and my notes say, this patient has thoracic neuritis, then radiculopathy is the code, okay? So these are inclusion terms. All of these conditions are also coded with M541. And if you feel really strongly that they're totally different conditions and you want to be clear on that, then you use your record to document that. You don't worry about the fact that the codes don't reflect it as well as you'd like, okay? So that's what that rule is telling us, okay? Very good. So here's some more. And this one is critical because I heard Primera and Alaska's cracking down. I think that we'll start to see this as a trend that payers are going to begin to crack down on exclusion edits, okay? In the Icd-10 instructional notes, we were given this thing called excludes 1 and 2. In Icd-9, there was this exclusion thing, but now we have 2 types of exclusions. And I really don't like the way they set this up. I think they could have done it better. If they'd asked me, I would have suggested a different way to do this. If you see a code and then it says excludes 1, that's used when 2 conditions cannot occur together. It's not coded here. They're mutually exclusive, and you should not use both of those codes on the same claim form. If you do, I'm telling you that payers will reject it. And if they haven't in the past, they may start to do it in the future. Okay, this rule's always been there. It's just that payers didn't enforce it. And now they found one more thing they can use to deny claims. So all you got to do is figure out what the rules are and don't use 2 codes that don't go together. Okay, excludes 2 is different from excludes 1. It means that these 2 things are not included here, so they could be part of the same. You could code them both, but you don't get to include them. Consider these codes in addition is the way I want to say it, all right? The excluded code and the other code could be used together if the documentation clearly supports them both. Let me explain better. Excludes 1 means here's a code, and under this list of excludes 1, consider these codes instead. You can only use one from this list or the one that you started with. They're mutually exclusive. Excludes 2 means look at these codes in addition to the ones that you've coded here. You can use 2 or more. They are not included automatically, okay? Now, if you find the convention of includes, a code says includes, that further defines or gives examples of the content, okay? So let me give you an example of this, and this is a snippet out of a coding book. This is S33, which is for dislocation and sprain of joints and ligaments of the lumbar spine, pelvis. You'll notice that there's a bunch of includes notes at the top, which means that if you're using codes that begin with S33, it includes all this other stuff, okay? It could include any of these other things, okay? And by the way, I look at these codes and I go, man, these are pretty serious. I mean, traumatic rupture of joints, I'm not going to adjust someone who's had a joint ruptured, right? Excludes 1, there's a couple of codes there. So what we learned from that is that these lumbar sprains do not include obstetric damage. You cannot code for someone who's had obstetric damage to the pelvic joints and a traumatic sprain. Excludes 1 says those 2 codes can't be on the same claim and they will get rejected, okay? Excludes 2 means you could consider these other codes in addition. And so if you had a patient with a sprain of the lumbar spine, if you look towards there under the excludes 2 list, I could code an S73 code to say that they've also had a dislocation, or I could also code an S39, which is a strain of the muscles, lower back, and pelvis, okay? They're not included. Excludes 2 means I should look at these in addition and maybe throw them on. And then we see code also, which in this case, it says code also associated open wound, if that's what they have. So here's some rules about that. If someone has an open wound and a sprain, you need to say both. That would be like your patient who comes in, like the kid that was sledding down the hill and you ran into a tree. You know, you would code for the other things that are related to that, even though you're treating the sprain strain. You would not point any of your procedures to those diagnoses because you're not treating the open wound. It's typically out of scope of practice for most chiros. So code first is instructions that don't apply too often to the musculoskeletal codes that we use, but it tells us how to sequence the codes. It tells us that another code needs to be reported, and you code first the etiology and then the manifestation. So let me give you an example of one that may apply to chiros. I have here, if you code for nerve root and plexus compressions in diseases classified elsewhere, code first the underlying disease. So if they had a nerve that was getting smushed by a tumor, code the tumor first. If you look at chronic gout, if you use that code, we are told to use an additional code to specify kind of what else is going on with that patient. And use additional means it goes second, right? Code first means it goes first. Okay, so one more rule, and then we're going to get into some documentation stuff. Hope you're still with me. Let me take this one question that came in a few minutes ago from Ronald. He says, if cervical pain, low back pain, and pain in thoracic spine are not acceptable as diagnoses, what do we list if there's no radiculopathy, no DDD, no spondylosis, etc.? I've been using somatic segmental dysfunction as a secondary diagnosis. Would that work? That's a great question. So here's the deal with symptom codes, right? And you've probably heard me say this before. It's why you asked the question. Cervical pain, low back pain, you can use those diagnoses. I want to be clear on that. You can list those as diagnosis codes in a case. You simply shouldn't if you have something better. So, for example, if I have a patient with mid-back pain and they strained the muscles in their mid-back, I should definitely code for the strain and not for the back pain, because pain is not a diagnosis. It's simply a restatement of their condition. So if a patient has no condition you can identify, but their back hurts, then yes, that's when you use those codes. Only use them when you have nothing better, okay? And keep in mind that a payer may look at those and go, well, I see that you've coded for that, but back pain, shoot, I could buy them a $20 thing of aspirin and they can feel better. So you need to justify your care. And I can justify care to treat a strain much better than I can justify care to treat someone whose back hurts, right? So if you can, with your clinical skills, identify a cause for the pain, then you're much better off. And you have much better records and better codes to support ongoing treatment, okay? But feel free to use the pain diagnosis. Just don't expect to get more than half a dozen visits. Or if you bill it out for 30 visits for just neck pain, expect them to come back at you later and ask for money back, okay? So we're going to change gears now, and I want to talk about, oh, no, I can't change gears yet. I want to go back to this rule. This rule was added in 2016, I think, and I think it's very important. It forms the basis for what I'm going to talk about for the next 20 minutes, okay? Oh, actually, I need to back up and tell you what your quiz questions are. I'm going to ask you to define what excludes one means, okay? And it means not included here. Wait, right? Yeah. So one of the quiz questions is, what does excludes one mean? And then the next quiz question, it looks like, is based on this screen right here. It's how do you assign the code? So this guideline out of the Icd-10 rules says the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. So this is where I got the phrase diagnostic statement, which is the title of this presentation. Okay, diagnostic statement. The question is, how do you assign the codes? And this is the answer. You assign the code based upon the doctor's statement that a patient has a condition, not upon the clinical criteria, not upon the opinion of the patient or what the payer wants. You choose the code based upon the provider's opinion of what the patient has, okay? And so in some cases, one of the reasons I think they came out with this rule was they would find a medical coder looking at the doctor's record and going, man, this patient has really high blood sugar and they pee a lot and their feet are going numb. They probably have diabetes, but the doctor never said diabetes in there, so the coder just picks diabetes. And this rule says you do not choose the code based upon the clinical criteria. If they pee a lot and they have high blood sugar, that's not enough. It needs to be the provider saying this is what they've got, okay? So the point of the rest of this presentation today is for you to be able to say this is what they've got. And that way when you get audited, your records are supportable. When someone reviews your records, you want them to be able to agree that you've chosen the code that is relevant to that case, okay? So keep this guideline in mind, and yeah, that's the quiz question. How do you pick the code assignment? It's what the provider says. That's how you pick. That's how you choose the code. What the provider says the patient has. So I put together this clinical example, and I'll confess right now, I made this like 3 years ago, okay? And actually one of the codes in here is actually already outdated, but we're just gonna look at this example and use this to kind of illustrate some points about how your records can support your diagnoses, okay? Okay, so let me just kind of summarize what this case is. It's a patient who comes in whose neck hurts after they were rear-ended in a car accident, okay? And they have some real simple findings. Yeah, just neck pain. They were in a car accident and the neck hurts. And if you look over the exam, you can see that I did some basic stuff on the neck, okay? Now this note is not intended to be an example of a perfect history, a perfect exam. I've just included information that's relevant to the lesson I'm trying to teach today. So if we take a look at this, we've got 6 codes assigned to this case. And frankly, the last 2 are not that important most of the time. I'll explain them though, just to kind of teach you a little bit about them. But really, we're going to look at these codes and try to understand what's going on with this case and how we can best document support for these particular codes, okay? So first, the first code there is S13.4XXA. And so if we were an auditor or a peer reviewer and we were trying to figure out why did the doctor assign this code to this case? Sprain of ligaments of the cervical spine, initial encounter. Why is this here? How did it get here? Well, we go up and we look through the record, and all I've given you is a little bit of a record. I've given you a little bit of history, a little bit of an exam. The question is, what in there supports that there was a sprain of the cervical spine? And one thing is that the patient was in a trauma. Okay, so sprains are typically associated with a trauma. Some of you may feel that you can diagnose a sprain without a trauma. That's fine. You're the clinician. You decide. I'm telling you as a clinician, I believe that trauma, my opinion, needs to be there. But I'm not saying that's the only way to do it. Keep in mind that Icd-10 does not tell you how to be a doctor. You still get to decide what clinical criteria you use and what the patient has. The code sets are just the objective information you apply to the case. So in this case, if I look through the exam findings there, I can see three things that supports the use of this code. I think a sprain is supported by the fact that I found pain during passive assisted motion. So a little anatomy review for you. Ligaments are tissues that attach bone to bone, and they, in and of themselves, cannot contract. They simply hold bones together. And so one way we can establish those problems with ligaments is by tests that use passive motion, which means the patient is not contracting their muscles. They're just laying there, and the provider or the clinician is moving them around and doing things to see if they can assess damage to ligaments, which have to be moved passively. Okay? So since that's in there, it supports that there could be a sprain in this case. Also, it looks like I took cervical flexion extension x-rays, and they showed increased anterior translation, which may imply that the patient's bones are less stable. Okay? And we see that in this case. Hang on. There we go. Okay, great. No questions so far. I'm just waiting for someone to drop a question on me. Some of you out there may be an expert in neurology or diplomat in orthopedics, and feel free to challenge my rationale here. That's not my expertise. Mine is all about codes and those rules. So I am happy to have a dialogue if you feel like you can make this more clear. So here's the problem with this. An auditor, let's say the auditor is a dummy, okay? He does not know chiropractic. He doesn't know anatomy. He doesn't know anything about health or healing of the human body, but he has this book right here, okay? He's got this book, and he's read the rules, and he knows what the rules are, and he's looked up the codes, and he knows what the codes say. Well, a sprain of ligaments of the cervical spine doesn't say anything about passive assisted motion or anterior translation. And so a coder may not be able to make the connection between the documentation I've highlighted here and the code itself. Therefore, I propose to you that you can't choose a code based upon the clinical criteria by the doctor's findings. Instead, it has to be based upon the doctor stating this is what the patient's got. And so I'm encouraging you to do that. So here's what we've come up with. It's this thing we call the diagnostic statement, okay? And I created this concept, this idea back when I was at ChiroCode, and I wrote a whole chapter on this idea, and that's where this example came from. If you look at this statement here at the bottom of your screen, it is a concise paragraph that outlines support, direct support for all of the codes that have been assigned to this case, which satisfies that guideline we looked at a minute ago that says you really gotta, the doctor has to come out and go out of their way and say, this is what the patient has. You can't just assume that everyone who reads your notes knows what clinical criteria makes up a sprain. So I've gone to the trouble in the middle of this paragraph to say sprain of ligaments of the cervical spine. And I took it one step further. I even put in there that the words used by the code set. So for those of you who remember Icd-9, there wasn't separate codes for sprain and strain. There was just a sprain strain code. And so it was sufficient to say patient has a sprain strain of the neck, and you could use the code. Well, in this case, I want to point out that this code doesn't say neck in it at all. It says cervical spine, because at the end of the day, you don't really sprain your neck. What you sprain is the ligaments that attach the bones, and the bones are the vertebra, and the vertebra are part of the spine. We're talking about the bones that were involved, that the ligaments are attached to. We're not talking about the region of the body, which is the neck. So I've gone out of my way to describe it the same way the code describes it, by naming the cervical spine and not the neck in my diagnostic statement. And naming the tissues that were sprained, with namely ligaments, being very specific about identifying what those tissues were. Because I want it to match the code, and I want an auditor to be able to find what they're looking for really easily. Okay? I'm not suggesting you have to go to these lengths. I'm just telling you this is ideal. This is like over the top, but it's accurate, and it's not that hard to do. So let's look at the next code, right? The next code is S16.1XXA, and this is the code for strain of muscle, fascia, and tenon at the neck level. initial encounter. Couple of lessons we can learn from this. Okay, look at that code. Notice the use of the word and. As you may recall, I told you earlier that and means and or, which means that the patient doesn't have to have a strain of the muscle as well as the fascia, as well as the tendon. It can be any of those three, or two of them, or all three, okay? So if you look up in my notes, you can see, I mean, number one, they had a trauma, so they were in a car accident, so that is typically associated with a strain. Plus, I've got the documentation that muscle pain is present during isometric muscle contraction. So again, contrasting with ligamentous sprain, for a strain, I have demonstrated that I feel it's present by the fact that I have findings that are tied to the muscles, not the ligaments. I had the patient shorten their muscles and it caused pain. That implies that the muscles may be damaged, okay? And so I've gone out of my way to document clearly muscle findings as well as ligament findings. If you go down to my diagnostic statement, when I kind of summarized what I thought, I tossed in there strain of muscles at the neck level. And again, I didn't say strain of muscles of the cervical spine because you know what? Technically the spine are the bones. So I'm going to say, like the code itself says neck level, it doesn't say spine. I'm going to go out of my way to talk about the spine when I describe the sprain, but I'm going to talk about the neck as the region where the muscles are when I describe the strain, simply because that's how it's done in the code. I'm letting ICD-10 codes influence my word choice, okay? And I think that that's going to make this more powerfully communicated to a third party who doesn't know what the clinical criteria are. He doesn't understand that isometric muscle contraction is supportive of the strain. So I have made it more clear by going out of my way to create a diagnostic statement as a clinician that says, here's what the patient has, okay? Okay, I'm hoping that there's a bunch of you nodding right now at the other end of on your computer somewhere. All right, let's go to the next code and let's take a look. Let's keep going here. We're on a roll. So this is the code I forgot to update, M79.1. This is myalgia. As you may know, last year they added a fourth character to this code. So pretend like I had the right fourth character. I think it would be 8, if I'm not mistaken. The thing about myalgia is that it simply describes muscle pain, right? It's very generic. It's not a very useful code. So you know, the question is, what was I doing here? Well, I chose to add this code to describe the trigger points. The reason I did so is because if you look up myalgia in the code book, there's an inclusion term under that heading that says myofascial pain syndrome, okay? And myofascial pain syndrome, according to Google, is synonymous with trigger points. So what I was looking for was a code that described trigger points. And myalgia is the one because it has an inclusion term that says myofascial pain syndrome. Does that make sense? I hope it does. So I've included the code here. Here's the problem though. Trigger points is a word I used and does not show up anywhere in the code set. If I look in the index in this gigantic book, the words trigger points are not in there at all. So I need to go, maybe I should either use different words or create a diagnostic statement that captures the words that a coder would want to see in order to agree with me that I've done it right. So I choose the myalgia code, not because I believe the patient has myalgia specifically, but because they have myofascial pain syndrome, and I added that to my diagnostic statement, okay? Because myofascial pain syndrome is an inclusion term listed in the code book under myalgia. And so there's myofascial pain syndrome. That's why I chose to add that to diagnostic statement. Okay? Now, the next code is M9901. There's my friend, segmental and somatic dysfunction of the cervical region. These codes are really critical for chiropractors. And the reason is, when ICD-10 came out, these are the ones that Medicare entities listed as the ones that should be linked to an adjustment. Therefore, I have a personal bias that whenever you see a patient who you believe needs an adjustment, you're going to provide chiropractic manipulation, that you should have an M990 diagnosis. Okay, one of your diagnoses should be M990, in my opinion. Because I want to be able to look at your notes and say, okay, you did this service and you did it because the patient had this problem. And if you argue that I said the patient had a sprain or something and that should justify the adjustment, I think I could get in there and say, well, not really, because someone who's got a sprain doesn't need an adjustment. They need to be put in like a cast or a sling, right? Because they tore something. You can't justify an adjustment with a sprain, in my opinion, at least an early acute stage of it. I think you justify the adjustment with segmental dysfunction or the subluxation, so-called. Okay, and that's my clinical opinion. You feel free to differ with me, but I think it's a great idea to include M990 as a diagnosis for any patient who's getting an adjustment. And then the fifth character, of course, is the region. In this case, the 1 represents the cervical region. Now, remember a few minutes ago we said that and means and or. So keep in mind that the patient does not have to have segmental and somatic dysfunction. It can be one or the other, because and means and or. However, I'm a chiropractor, so I wrote in my record that I found subluxations at C5. Well, that's all nifty for me, and if another chiropractor reads my record, they might understand what I'm trying to say, but the problem is if you look up subluxations in the code set, it has nothing to do with chiropractic. Subluxations are partial dislocations that imply that something is torn and actually would be contraindicated to a manipulation, and therefore, I don't want to use the word subluxation for my auditor. I want to go ahead and be helpful to them and give them even more and tell them, hey, you should do, I give them the proper words. I give them segmental dysfunction in the cervical region. So segmental dysfunction, I don't have to list somatic as well. I include cervical region. I don't have to do the specific segment for the diagnostic statement. You do need to do specific segments, by the way, for Medicare. So you might as well include it in there. But what I've done is I've just taken the information from my history and my exam, and I put it into this diagnostic statement that's more closely tied to the codes themselves, okay? Okay, so this brings me to the last 2 codes here, which are not as important because they're optional, okay? But let's talk about them anyway, just for a minute, and then we'll kind of bring this all back together. And I'll when we get towards the end of the time here, I'm going to go over the quiz questions for you one more time to make sure you have the answers right at your fingertips, okay? So the next code I assigned to this case is V54.5XXA. Okay, and V54.5XXA is an external cause code. External cause codes describe where a patient was or what they were doing when they were injured, okay? And they are not required according to the guidelines, but they might be someday. I think they can be helpful for workers' comp or auto accident cases. I'm not aware of any payers that require them, but you can use them if you understand them well enough. So this code says driver of pickup truck or van in collision with heavy transport vehicle or bus in a traffic accident initial encounter. And if you look up there in my history, I've included some information that you can see supports some of the data in that code, but that code really has, I think it's got 4 or 5 bits of information in it, okay? And if I'm going to use these V codes, these external cause codes, I think it's important that I step up my game a little bit and make sure that each specific item or criteria that the code requires is clear in my notes, in my record, okay? So here's what I did in this case. I added down there in the bottom in my diagnostic statement 5 specific items so that's super clear to anyone who's auditing. They can find things that explain what this code is about. First, I specified it was the driver, you know, and up above in my history, I forgot to mention they were the driver. I mean, maybe it was a given, but I didn't say it. So I specified they were a driver because the code has that information in it, and that needs to be documented in order for me to support it. I specified they were driving a pickup truck because this is the code for pickup trucks. There's a different code for passengers. There's a different code for different types of vehicles, but this was a pickup truck. And then they used the word collision. You know, and I said rear-ended, and I think anybody can figure out that rear-ended and collision is the same thing, but you know what? The code says collision, so I'm going to use the word collision in my records. If I'm going to use these codes, I want my records to reflect them, and I think that from now on, I will use the word collision, knowing that that's the word of choice from ICD-10. Am I being overly picky? Do you have to do that? You don't have to do this. I'm just telling you that that's what I would do if I wanted to make it really, really slick, okay? You don't have to say collision. You can assume that the person reading knows what a rear end is and they understand what it means to be rear-ended, but I'm going to assume that everybody looking at my records are stupid and they don't understand any of that, and so I'm going to make it super easy so they can just match up the words. If they can read, they can be satisfied with my records, okay? And then I put in bus because the code says what they were struck by. There are other codes for being struck by other things like other vehicles or another truck or you know, inanimate objects or whatever. And so I went ahead and specified something right from this code description. And then I put traffic accident because, believe it or not, there are codes for non-traffic accidents, like if you run into a tree or something out in the middle of a field. So I went ahead and added traffic accident. I mean, I have collision in there and traffic accident. You think that'd be redundant, but the code has both, and there are different codes for non-traffic. And so I want to make sure that I include that information just to make it as clear as I possibly can. Okay. I got a question that came in. I'll pause and answer this one because it's kind of important. He says, do these diagnostic statements need to be only in the initial and interim exams or on every daily note? So I should clarify this. You don't have to do diagnostic statements at all right? You guys are the super users. I am giving you what you can do to be above the bar and do better than you could otherwise and make your notes even more bulletproof, right? So you don't have to do a diagnostic statement. I'm suggesting that you should, however. And in my opinion, they should definitely occur at the initial encounter. I don't think they need to be restated at subsequent visits. I think that's redundant and a waste of space, and it's just fluff. But if something changes, for example, in this case, if it was a month into care and the patient no longer had the trigger points, I would remove that, and I might restate my diagnostic statement without that information in it about the myofascial pain syndrome. So I think you do the diagnostic statement at the initial encounter. You could do it at a subsequent exam, a re-exam, if it changed. And if it doesn't change, I don't know that you even need to restate it there. It might just be the first visit, okay? And if you, at the end of the care, I guess you could do it again and say, the patient's being discharged with these residuals or something, and you could add what's there if you add those diagnoses in that case. So that's my answer to your question there, Warren. Question from Pat about where this might go in the PayDC notes. I'm going to come back to that at the end. Keep in mind, I developed this idea before I worked with PayDC. This was back when I was at ChiroCode, and I stole these pages right out of the book when I wrote this up. To be frank, a diagnostic statement is more of a free text thing than anything else if you want to employ it, because it's not there's no way to automate it really. It's kind of based upon your opinion. So look at this, use it if you want to. When we're doing so let me show you a little bit more, and we can come back after we finish the CE portion of the webinar, and we can look at the notes and try to figure out some things together. Or you can email me, we can talk about it. We can try to sort it out and find the best spot for it. I think it belongs in the additional notes section of the assessment part of the record. The final code in this case is street, highway, or other paved roadway. It's also an external cause code. It describes a location. It's a Y code, okay? And if you look up in the notes, the only thing that really explains that is the stoplight, right? I'm like, well, is that a paved roadway? Maybe, maybe not. I've never seen a stoplight on a dirt road, but maybe they happen. So I just added in my diagnostic statement information that it was a paved roadway. Now, you might also note that that code is unspecified, which is kind of interesting because I told you earlier not to use unspecified codes. And unspecified is synonymous with the acronym NOS, or not otherwise specified. It's one of the quiz questions. It's okay to do unspecified if it's all the information you have, all right? So if all you know is that it was a paved roadway, then choose the unspecified code that describes paved roadways, and you're fine. So those are the 6 codes that I think fit for this case, but there's one other issue to address here, and it's the use of the final or 7th character, okay? And in this case, I chose the A for the codes that require it for initial encounter. Now, to remind you, I don't believe that because it's the first visit, that's the only reason that I get to do the A for the initial encounter. However, I think that a great way to justify the A as the 7th character is to state very clearly in your records that this is active treatment, okay? Because the A applies to any portion of the care that is considered active treatment. Therefore, I strongly encourage you to include that phrase somewhere in your records if indeed you attach the A to any of the codes that you're billing out. Because I think that supports it better and more clearly than any other statement I can think of. And if you don't think the patient's in active treatment, then don't say that, right? Then if they're not in active treatment, that means that you believe it's aftercare, follow-up, recovery, and you can state that and use the D as your 7th character, or the S for Sequela if you think it applies, okay? So that's the gist of this this diagnostic statement and this, this example that I've pulled together for you, okay? Let me see, any other questions? There was another question that came in. Actually, so Mark, you asked a question about a dorsopathy code. Could you submit that again or elaborate for me? I'm not quite clear what you're trying to ask about. So go ahead and submit that question again. And I want you to other questions you guys have about this, this diagnostic statement and this concept before I move forward. Because I want to make sure that it's clear for you. Okay, I'll watch those. I'm gonna see if those are coming in over here. I'm gonna do this. I'm I'm going to change my screen for just a second here. So bear with me. I'm going to show you something a little different. So hang on one moment. Just a second. I'm getting there. I'm getting there. So a couple things I want to show you. Let me pull the screen back up. Right there. So I'm inside the software now, and I want to just talk briefly about where diagnosis codes come from, where they fit, and all that. When you're inside of a patient account and you go into the care plans, this is where you assign the initial diagnosis code. So I'm going to edit this care plan on Dwayne Johnson. I don't know if you guys knew this, but he's my patient in my fake account, but you know, better than nothing. So just a reminder for you on how to use this portion of the care plan wizard. I'm inside the care plan. I'm using one of my previous templates, and I can see my diagnosis codes here, and I have them kind of sequenced in the hierarchy that I like. Diagnosis code sequencing is important as well. To just summarize, you should put the most serious condition first at the top of this list, because that's how it's going to appear on your claim form. And that conveys to the payer what the primary reason is for the encounter. Okay, if it's a Medicare patient and the M990 has to be first because Medicare requires it, and then just make it first and leave it that way. If you need to change your codes, again, on the left, you have your favorites list. You can change this list in the settings in your software. You can add or take away from it if you don't like the codes that are in here, or I want some new ones. You can shorten it down. You can make it longer, whatever fits your needs. And remember, you can sort this list alphabetically. You can sort it numerically, and you can type in a keyword to look up, you know, for example, this is shoulder. There's all my shoulder diagnoses. I have about 20, 25 in there, and I can go through and add, you know, bursitis or something, toss it in. Okay, so this is kind of where we interact with the diagnosis codes in the care plan, and it forms a foundation for all the visits that follow. In the subsequent visits, though, you can change and update those codes, okay? And so you don't have to stick with these forever. You might find that there's no more muscle spasm and you delete it after the 5th visit or something. But this is where it gets started within the system. I'm going to cancel this and jump in to a note on Dwayne. And we'll open this up and so down in the assessment is where you change the diagnoses. And for those of you who are unfamiliar with it, you know, you can take codes, drag them back and forth. You can move this one up here to make it more important. If you don't like this code, you change your mind, you can put an X and get rid of it. And when you do this, the software will automatically ask you, once you sign the note, if you want to update the care plan so it's only these 5 codes from here on out instead of keeping it with the 6 that the care plan outlined, right? And we can add more diagnoses here as well. It's the exact same interface as we saw in the care plan wizard. There's my favorites list of about 150 codes, and I can just check off the ones I want to add. I can sort these alphabetically or numerically, and I can type in keyword search, you know. And I can search for all my cervical diagnosis codes, which is these, you know, there's about 25, 30 of them, it looks like, and add one in, okay? So you have these 2 places in the program where you add and take away your diagnosis codes. At this point in time, if you really want to go to town with the diagnostic statement, I think that its most appropriate location to be here is an additional note, because the software can't generate it automatically because it's so customized at this point. I'll think about it though, and give me, you know, 6 months or a year, and we'll figure out a way perhaps to make that a part of the system. One of the beautiful things about a cloud-based system is we'll update it and you get the updates. You know, they just come out when the system, you know, when you log in the next time. So so that's just kind of those couple things I want to show you about where the diagnosis codes live and how they tie in. So hang on a second. I'm going to go back over here. Just a moment here. Let me get this back up. And I just want to do one more thing with you. Let me share my screen again. There, right there. So what we've done is we've reviewed some fundamental guidelines for Icd-10, and we've created the diagnostic statement and talked about how it's value in a case and how you can toss it in there. I just want to review with you real quick the quiz questions you're going to see. As soon as you end this webinar, you should get within a minute or two, complete the survey questions. There's actually 8 questions. 5 are from the content and 3 of them are feedback for us so we can do a better job. I also want to remind you that I think it's June 20 something. There'll be an announcement coming out. I'm going to talk to you about specific conditions and diagnosis codes and what specific information should be documented for specific codes to support them. And we'll dive into that in a month. That's also a CE-based webinar like this one. So here's your quiz questions. You need to know what the 7th character Sequela is for. You need to know what NOS stands for, which is unspecified. You need to know what excludes one means, which means not included here. You need to know that codes are assigned to a case based upon the provider's opinion, no one else's. And you need to differentiate. Oh, the other question is, you need to differentiate between a sprain and a strain. How do you do that? And I forget what the answer is, but I think it's something like you differentiate between a strain and a sprain by saying either the specific tissues involved and talking about passive motion versus active motion. I don't recall. If the question's really hard and everybody misses it, then I'll like grade on a curve, okay? So hopefully that won't be a problem. So having said that, I have a few questions here to go through, but that is everything I wanted to share with you. And so we're looking pretty good on time. Let me go through these last few questions if you guys want to add them in. And then again, stay on the line. When I end the webinar, you will get the questions, okay? So, and I think you get them also, if you don't do it, you get them in an email an hour later. So stay tuned. But let me field a few of these questions. So Mark's question was, when justifying an adjustment, can you use a dorsopathy code in place of an M99? So Mark, that's a great question. Dorsopathy is generic term for pain in the back, right? Or a condition in the back, some problem with the back. And here's my answer to you, maybe. But if I really wanted to be a jerk and challenge you on it, I'd say, well, why would you adjust them just because there's something wrong with their back? What is the thing that's wrong? What justifies an adjustment? It's segmental dysfunction. It's a subluxation. And I can fall back to Medicare as my reference for that. So if you feel that you could stand in front of 100 chiropractors or 10 chiropractors even and say, look, I do an adjustment because of this dorsopathy, and you name this dorsopathy, and you think that the adjustment directly ties to that, then you can make that argument. That's fine. I'm not telling you one way or the other. That's up to you. So that's available to you. You're the clinician. You decide. I think, in my opinion, that segmental dysfunction is the best diagnosis to justify an adjustment. Allison is asking, I see you have times reported in your additional notes in the plan. I know it's not part of this call, but is that, oh, I should have saved that question for later. All right, well, let's just talk about this real quick. Time-based codes, total time is what's required. I have heard of 1 or 2 payers beginning to say you need to put in a start and stop time. In the example that you looked at, I was showing a prospective client how we could do that. I created a macro that said start time blank, end time blank, and all I had to do was type in the time amounts, the exact times. If a payer requires you to do that, that's how I would suggest you do that right now in the software. Again, that's another feature I think I'd like to add as an enhancement someday in the future, especially if payers begin to really crack down and require it. I want to find a way to automate it for you so it's faster than just typing in the numbers, okay? And Allison, you're welcome. So that is everything I have for you today. The quiz is coming up here as soon as I end the webinar, so make sure you answer those questions, because if you don't get the credits. Okay, to be clear, for those of you who need your credit hour. And we only have one more credit hour webinar scheduled. It's going to be in about a month. However, we are working on a couple of webinars that are much more focused on the software and how to use it and get more out of it. These last 4 or 5 webinars that I've done, and Dave Klein did one, were more about CE credits, and we were limited about showing you the software and what we can do to improve your user experience. But we're going to revive some of those and do some of those kind of over the summer months. All these webinars are saved, recorded, stuck on the website. You can rewatch them and come back if you need to refresh your memory. Okay. If you guys have any concerns or questions, my email address is right there on the screen. Shoot me a message. I'm happy to help out. And it was a pleasure to have you here. Have a great week, and we'll talk to you at the next webinar. All right. Call us if you need anything. And awkward silence. Bye-bye. Bye-bye.